evaluation of the Health Facilities Enhancement Program. I would first like to recognize the rest of the team who are here. Of course, Mr. Oscar Picasso, Ms. Danica Ortiz, raise your hand, and Sir Juan Alfonso Tanghal. The rest of the team members are not here, Ms. Nina Ashley De La Cruz and Melanie Albion. Okay, so just to give you an outline of the presentation, I'll start with the introduction. I'll introduce HPEP as a program. Then I'll give you a background of the study. And then we did two phases of the study. So we started with the process evaluation, which looked into the receipt, completion, functionality, and sustainability of HPEP investments. And the second phase was an impact evaluation where we assessed the net effect of the program utilization. Essentially, we looked at utilization rates. And then we'll be providing general findings and policy options. So, for those who are not familiar with HPEP, if there's anyone who's not familiar with HPEP, it's, as what Dr. Lente said, it's one of the banner programs of the Aquino administration for the upgrading of facilities through investments in infrastructure and medical equipment. So these are grants provided to hospitals and RHUs, and the aim of HPEP is essentially to upgrade priority barangay health stations and rural health units, provide BMO services for the reduction of maternal mortality. Second is to upgrade government hospitals and health facilities in provinces to make them more responsive to the health needs of the catchment population. Third aim is to upgrade lower-level facilities to be able to accommodate nursing students and to establish gatekeeping functions to avoid congestion in higher-level hospitals. Let me make it clear that this document was from 2008, when probably had issues with surplus of nursing graduates and students. And the fourth is to expand the services of existing tertiary hospitals to provide higher tertiary care and as teaching and training hospitals, both for doctors and nurses. So, background of the study. HPEP, in addition, has prioritization every year. So, it started in 2007, but in 2010, the priority was to upgrade facilities into BMOC or CMOC facilities and to build blood facilities in regions with high MMR. So at that time, yung problem was, I guess, high MMR. So priorities were to make sure that the barangay health stations or the RHUs are BMOC or CMOC capable. And then in 2011, the thrust was to improve the BHSs and RHUs, upgrade them into BMOCs, and upgrading of DOH hospitals. So every year, meron silang different prioritizations. And every year, tumataas din ng tumataas yung budget ng HPEP. As you can see in the graph, in 2007, the budget was 43 million, but in 2016, that's 26.9 billion. So in a decade, that increase has actually prompted, in one way or another, the Department of Budget and Management to include HPEP as one of the projects under the impact evaluation for PIDS to conduct, as what Ms. Sheila mentioned. So, we did two phases. The first phase was done last June 2014 to April 2015. And the second phase was conducted last May 2015 to January 2016. For us to proceed, we had to look at available literature on the HPEP. So, konti lang kasi yung literature on HPEP, and this is what we found. 5 studies or papers directly related to HPEP. And if we do a summary by theme, we found out that HPEP, during its initial years of implementation, has been problematic in terms of implementation, in terms of identification and planning. For example, we find results like there's no link between the allocation and the province's poverty incidence or needs based on the PIDS, or you also have findings like there's underestimation of time and resource constraints. For example, the costings for barangay health stations are based on BHSs in for example, Metro Manila. But when you have to build a BHS in Ifugao, where the costs are much higher, then we have resource and time constraints in terms of construction. And then other issues such as, for example, sustainability of financing. Hospitals and RHUs, as we all know, with the devolved setting are under the local government units. But if you look at the trend of LGU financing for health, it's going downwards. So in terms of sustainability, it's probably going to be an issue for the sustainability of the HFEP recipient hospitals and RHUs. But there are good sides of the story. Like for example, certain investments were able to correct existing spatial maldistribution of facilities, and that there are also findings that BIMOC RHUs had improved service abilities after HFEP investments. So we used these as our background in conducting our study, and therefore we came up with these objectives. So the purpose of our study was to look at the state of funding and completion of HFEP projects, to look at the functionality of the completed projects, utilization of health services in HFEP recipient facilities, and look at the sustainability of the HFEP investments. For those familiar with the HFEP process, it's actually a very long and tedious process. So it starts with budget allocation, costing and procurement, but we didn't include those segments in our study. We only focused on project implementation and completion, functionality and utilization, and sustainability. So to move forward, we conducted facility surveys. We went to hospitals, all levels, and RHUs. We looked at secondary sources, and during our interviews, we gathered these information, essentially basic facility profile, the amount of HFEP support that they received, the different equipment that they received, and problems encountered, as well as outputs and operational indicators. So we visited 31 provinces in a span of 1.5 years. We completed individual facility surveys in 174 RHUs, barangay health stations, and city health offices, 123 hospitals and infirmaries. So if you look at the map, we were able to cover all those provinces in red. And as per the sampling frame, as much as possible, we try to identify 2 provinces per region. But then when we contact the provincial health offices, we would have to coordinate with them which facilities we can visit given our time and resource constraints. That's why we came up with these numbers. We didn't include the BHS, although there were a few BHS that the PHOs insisted that we visit. And we didn't include the DOH retained hospitals in this study. So this is just a breakdown of all the facilities that we visited. Again, we have to emphasize that we did 2 phases of the study. Bulk of the data for the second phase actually came from the second phase. And so proceed with the results. Again, just to remind you, this is from the process evaluation phase of the study. So we looked at the completion and functionality. We asked the facilities how long does it usually take to complete the facility, the construction, the upgrading of the facility. So for working clinics and standalone clinics, it's usually 1 year. Rural health units or city health offices, 1.8 years. Infirmary, 3 years. Level 1 hospitals, 3.7 years. Level 2 hospitals, average of 4 years. But it's not enough that we look at completion. We found out during our field visits that the facilities may be complete, but they are not functional. So out of 23 RHUs, only 11 are fully functional, 5 partly functional, and 5 non-functional at all. Same story for hospitals. Out of 19 hospitals, only 8 are fully functional, 5 partly functional, and 1 non-functional. So for example, we went to Caramoran District Hospital in Catanduanes. was partly functional because their only issue was there was no concrete separation for the adult male and adult female wards, and that the toilet is not separated, so they had to close down that ward. And then in another RHU in Tarlac, it was a completed birthing home, but there was no doctor, so it was not in operation. And I think it was already completed for 2 years. 2 years, so it was just there. We asked the individual facilities if they encountered any problem with civil works. So, if I point here, 83% of the RHUs reported at least one problem. So the usual problems are, for example, decanting of patients while infrastructure is ongoing, the delayed startup of infrastructure, minor defects, major defects in infrastructure, completion, delayed completion of infrastructure. If you look at the photos, this is Ibisamar issue in Capiz. It's the MHO complained of poor quality. It looks really nice from the outside, but if you go inside one section, tumutulo yung kisame, pangit yung plumbing, pangit yung toilet and everything, so they use that section as temporary storage. If you look at this one, you have minor, major defects in Banos RHU, and in Hinatuan, in Surigao del Sur, there was construction delay. This was a very common story in most of the facilities that we visited. And if you look at hospitals, 84% of the facilities we visited reported at least one problem in civil works. And almost the same issues, delayed completion of infrastructure, minor defects, delayed startup, and then there's variance between approved HFEP infrastructure and licensed level of facility. Like for example, the structure approved for HFEP upgrading is level 1, but then the land area is only capable of having an infirmary. So nagkaka-issued sila with the implementation of HFEP. That. I have more photos to show. This is in Manukan Community Hospital in Zamboanga del Norte. They were constructing the wards and the operating room. So they had to do the consultations outside. So nandun sila sa labas, sa Alicabok. And then this is in Cortes Municipal Hospital in Surigao del Sur. There are unfinished constructions, X-ray room not up to standard, and then there's a need for additional funding which was shouldered by the provincial local government unit. This was supposed to be their, not sure, one of the halls, part of the hospital, but HFEP funds ran out, so the provincial local government had to chip in just to complete this part of the hospital. And then, as I was saying, this Senator J. Rojas Memorial District Hospital in Capiz. It's a huge hospital, 50-bed capacity, but then it was only approved as an infirmary, license level as an infirmary. Because of minor requirements, like the hospital didn't have a separate prayer room, which was part of the DOH licensing requirements for level 1. So therefore, it's only operating as an infirmary, not as a level 1 hospital. So we triangulated our survey findings with the results from UP HPDP. They have this KPOM operations monitoring, and they looked at the rate that the civil works were completed in both hospitals and RHUs, and it follows almost the same trend that we found out during our survey. So we had very low, 50% of the hospitals were completed, and same for RHUs. The next issue we looked at is at the delivery and installation of medical equipment. So for RHUs, again, 89% of RHUs reported at least one problem with medical equipment installation and delivery. This is very interesting. 28% said their items that we did not request for. So it's either dumoble yung na-deliver sa kanila or binigyan kami ng equipment na hindi naman match sa aming license level. Issues like that. And then there's too early delivery of equipment. Na unang equipment, hindi pa nasa-start yung civil works. So they had to look for areas where they can store those equipment. And then there's also late delivery of equipment and other issues for our issues. This was a common sight during our field visits. There were a lot of equipment waiting to be installed. You find it everywhere. And in Zamboanga del Norte, there were so many microscopes in an RHU. And in Catanduanes, San Miguel RHU in Catanduanes, the dental chair had faulty hydraulics, so it was just there, steady lang yung dental chair. Hindi rin ma-maximize ni dentist yung dental chair. Other issues such as voltage problems, you have an autoclave that they couldn't use, and in Zamboanga del Norte, the dental chair holds it in the dental room, so they couldn't use it. Proceed with issues of hospitals with medical equipment. 74% of hospitals reported at least one problem, either non-delivery of equipment or delivery of inferior or substandard equipment. The usual complaint is 1 week lang tumatagal yung mga sphygmomanometer namin. Or late delivery, voltage problems, almost the same issues. For example, in Tarlac Provincial Hospital and 2 other hospitals, there were lapses of warranty period prior to use and poor after-sales servicing. So pag nasira siya, they didn't know who to call kasi dinideliver lang sa kanila yung equipment. And then in Catanduanes and in Zamboanga del Norte, nakakalat lang yung mga equipment nila. And 9 infirmaries and hospitals said they didn't receive any equipment. So again, we triangulate with findings of PAN. Same trend. So yung receipt nila of the equipment that they requested did not arrive as scheduled. And then we move on to the next aspect of analysis, is on the utilization and sustainability. Every time we visit a facility, pansin mo naman na punong-puno yung mga facilities, ang dami-daming tao. So if you look at these numbers, for example, in San Miguel Catanduanes, in an RHU with 100 patient consultations in a day, that is so much work for the MHO. So we have 3 facilities reporting 100 consultations on average. So ibig sabihin lang ito, I guess the HPEP investments, the HPEP recipient facilities are being used, optimized, maximized. So these are just photos of what we saw during the field work. So this is San Miguel RHU. This is a birthing center na masayang-masaya yung mga moms kasi meron silang paanakan in the area, in Biga RHU. And pagpunta namin usually mga tanghali na at marami pa rin tao. So ibig sabihin, gamit na gamit talaga yung mga RHUs na to. If you look at births in RHUs, walang po in Zamboanga del Norte is a very interesting case. Kasi napaka-proactive ng kanilang MHO. So they built a very nice birthing home in the RHU. That's why they can average 300 births in a month. And sa totoo, in San Miguel Catanduanes, in Tayabas, Quezon, you have an average of 90 to 97 deliveries in a month, and that's also a big number. So these are some photos. This is Palamco RHU, Tigunan RHU, and San Agustin RHU. Outpatient consultations in hospitals. Again, we have a lot of consultations in hospitals as well. Eastern Legal Medical Center, Gumaka District Hospital, an average of 90 consultations per day. If you look at the OPD section of hospitals, you see these. So, marami talagang tao sa mga hospital natin. And then, move on to the sustainability aspect. In terms of sustainability, our facilities, our public facilities, are relying on PhilHealth income. Although we don't have the numbers today, but a growing share of their income is actually sourced from PhilHealth. So, if we look at these numbers, only 68% say for RHUs and birthing centers that we went to have the MCP PhilHealth package. So it means that goes for other benefit packages as well. So it means that there's space for these facilities to take advantage of this privilege for extra income from PhilHealth. But we're not, there are a lot of reasons why these facilities do not get accredited, and maybe we can cover a little bit of those issues later. And the same story goes for hospitals. PIDS is pretty low. MCP for hospitals and inpatient care, of course, is 100%. And then we looked at the share of PhilHealth in hospitals. We get information from PhilHealth that, PhilHealth people, the coverage rate is at 92%. So if we go to hospitals and we ask the medical directors, estimate nyo ilang percent of your patients are PhilHealth members. So we get varying answers, but we get numbers like 40%, 46%. Majority are still below 50, 60%. Ginayangan District Hospital in Quezon is a different story. This is a very far-flung town. It's almost near Camarines Norte. So the medical director was very proactive in enrolling most of the community members into PhilHealth. That's why lahat ng pumupunta sa kanya, PhilHealth members na. And apart from enrolling them, ina-educate pa niya na kapag PhilHealth member kayo, wala kayong babayaran sa hospital. So, kilala doon ang PhilHealth as NBP, meaning no bayad-bayad, but not the no balance billing company. So, kanya-kanyang strategy yung hospitals in getting more PhilHealth patients into their hospital. It's clear on the other side. We want to show here that in terms of comparing PhilHealth inpatients and revenues per year, this is the same hospital. Ginyangan Hospital in Quezon only has around 15 inpatients per day, but it gets around 23 million pesos in PhilHealth income every year on average. So, ito naman, it has 91 PhilHealth inpatients per day and gets 64 million from PhilHealth every year on average. So, what we're trying to point out here is nasa kanya-kanyang strategy na ng medical director siguro on how to take advantage of the extra income that they can get from PhilHealth in terms of sustainability na rin ng facility nila. And then the next layer of analysis that we did was to look at, to compare the trends for the periods 2006 to 2015 for facilities with and without HFEP. So without HFEP meaning they didn't get any grant for HFEP, or if they got any grant from HFEP, it was not involved in any direct medical care provision. Like for example, waiting shed lang yung HFEP project nila. And then the other layer of analysis that we did for utilization was comparing the trends for with and without facilities before, during, and after HFEP. So let me just show you some of the figures. This is comparing the average number of inpatients per day, outpatients, and birth deliveries in hospitals for facilities with and without HFEP. So the positive result of HFEP was evident in hospitals for inpatient care. If you look at the trend, pataas yung number of inpatients, average inpatients per day for facilities with HFEP. And for outpatients, you see a medyo stagnant siya and a slight decline. And for birth deliveries, it was going up and then it went down. So I think that the result that we want is And maybe another reason that we want you to take note of is we were not really able to gather a lot of facilities without HFEP. Every time we talk to a provincial health officer, we also need to interview to see facilities without HFEP, and then they would say, wala na po, lahat po kami HFEP. So, nagpilit na lang kami, like for example nga, waiting shed lang yung HFEP grant nila, then we would have to consider that as without facility. So therefore, we only have 6 as our end.
Meron bang HFEP na, waiting shed na?
Meron po. We found it in Zambales. Hindi po, so essentially, their facility, their RHU was functioning.
VHS RHU Hospital. Wala naman kami na-approve na waiting shed.
That was what we gathered from, this is in Iba RHU.
Iba RHU?
I think, hindi ko lang po alam kung ano nangyari with, their RHU was functioning.
Wala naman hindi lang natapos, pero hindi siya waiting shed.
At, maybe at the time that we were there.
DPWH yun eh. Kung baka yung ginawa ng DPWH, kasi ang HFEP, may ano yan eh, ang nag-implement yan, DPWH yun. So yung hindi natapos, baka yun ang ginawa waiting shed.
It was a waiting shed attached to the PIDS area para may waiting area for the TB patients while they
waiting area siguro.
It's waiting area, not waiting shed.
Hindi kami nag-approve ng waiting shed eh.
And then, so the previous slide was for hospitals. This slide is for RHU. So we tried to compare the trends for RHUs with and without HFEP, and the results did not come out as expected. Kasi actually, bumababa ay yung utilization for with HFEP. So, these are the numbers that we got. We don't really know how to explain these numbers, pero we have a few reasons siguro later on we'll just discuss. And then, as I've said, we did another layer of analysis for before, during, and after, which is quite complicated because for an HFEP project, you cannot pinpoint when it started. Or you can pinpoint when it started, but not when exactly it finished. Hindi siya uniform across facilities. So this is what we did. For example, you have 5 facilities, and then they have different starting time for HFEP. So we consider these as before, the during is the HFEP implementation, and after the implementation. So it's likely that during the time that we visited, ongoing yung HFEP niya, or kakatapos lang, we couldn't really gather mga after na indicators. And I'll just provide you the challenges that we encountered in analyzing the before and after. So, one is that there's a staggered and prolonged construction and rehabilitation period requires health service data running as far back as 10 years. So, for example, we encountered facilities where yung construction niya has been ongoing for 7 to 9 years, and pagdating namin doon, hindi pa rin tapos yung facility. So that's one of the bottlenecks that we encountered with our data. Second, as I explained, there's no clear demarcation of before and after, and that health service utilization continues during the construction and rehabilitation project, often under adverse conditions of crowding, noise, dust pollution, and patient discomfort. And another challenge was that while most HFEP investments occurred on the same site, a handful of projects were done on a different site. So instead of upgrading yung existing facility, they just have to construct a new one. So kung ganon, mag-iiba na yung trend natin for before, during, and after. But anyway, we want to show you these figures because it shows a general trend that utilization has increased after HFEP. So before, it's generally an increasing trend for RHUs in hospitals, for outpatient consultations, for deliveries as well in hospitals, but we see a flat line for RHUs and CHOs, and for inpatients in hospitals. This one is comparing before and after for with and without HPEPs. So essentially, we see that the rate of increase for facilities with HPEP is greater than for facilities without HPEP. So we see that for birth deliveries, outpatients, and in RHUs and hospitals. So to summarize, these are our overall impression during the 1.5 years that we did field work. So despite the generally high utilization of services in health facilities, the following must be noted: that there has been little, if any, increase in the number of RHUs, although there has been a significant increase in PHS, many of which were turned into birthing centers. So essentially, upgrade lang kasi natin mga existing RHUs natin, and there's no, I don't know if there's any new construction of RHU. For the most part, HPEP is just replacing old hospital capacity. There is no completely new hospitals. The new constructions are merely replacing old existing hospitals with no major expansion in bed capacity. New services are being established with the new improved health facilities. So these include CMOMs, animal bite centers, modern diagnostic and imaging centers, sewage treatment plants, and new morgue. And the service expansion is most pronounced in RHUs, which now have separate rooms or facilities for birthing and delivery, PIDS, dentistry, etc. So we did see a lot of RHUs na parang na rin infirmary kung mag-operate kasi kompleto na yung services nila. And the impact of capital investments is often diluted by staff shortage and dramatic contractualization of health workers, as well as persistent drug shortage. Analytical challenges. Remember the graphs that we couldn't really explain? So we identified two confounding factors. One is from the demand side, where we actually have higher health service utilization, but we cannot purely attribute it to HPEP. There are a lot of social health insurance reforms in PhilHealth, such as increasing the number of enrolled Filipinos, particularly the poor, stricter enforcement of the no-balance billing policy, and the migration and urbanization, which increase the catchment population around the hospital. For example, you provide employment opportunities around this particular area, so therefore automatically tataas yung users of the hospital in that area. On the supply side, despite improving the supply side, we might see lower utilization, probably because of, for example, number one, impact of family planning program. We were asking one of the RHUs, bakit po bumababa yung birth deliveries nyo dito sa RHU? Kasi tinakasan namin yung family program namin. So that explains why. And then another is increasing number of birthing centers in outlying barangays. Kaya nawawala na sa poblasyon yung mga nanganganak, nasa barangay na lang sila. Increasing incidence of teenage pregnancy. Kung ganon, if they go to an RHU, they have to be referred to a hospital or a CMO. And then increasing role of private sector, and the change in licensing standard in 2013, which lowered the status of primary hospitals into infirmaries and secondary hospitals into primary hospitals, as what we saw with the district hospital in Capiz. To conclude, we have explained the shortcomings of HPEP with implementation, construction, equipping, coordination, and infrequent monitoring. And we also saw the lack of service delivery network plan for expansion and upgrading, including human resources. So we have facilities which are not operating dahil walang doktor, walang nurse. Then there's this building incrementalism mentality. I'll show you the next slide. So, for example, in Capiz, again, this is the main RHU, and then they say, oh, may pero tayo, sige, pagawa tayo ng another facility. So, the following year, oh, may pero ulit tayo, sige, pagawa tayo ulit. Lagay natin sa site. The same story for San Agustin RHU and Surigao del Sur. This is the main facility, and then they got HPEP funding, so nagpatayo sila ng birthing home sa likod ng facility. So kumbaga, patsi-patsi yung mga HVAC projects, investments. We only heard from, I think, 1 or 2 MHOs which mentioned na wala kasing master plan, yung RHU. Kaya ganito yung labas ng HVAC investments. And then, I guess, another issue that we covered is yung financial sustainability. So even if the facility is there, how can we ensure that local financing will still continue? And if hindi naman maasahan masyadong local financing, is there any way for the facility to generate its own revenues to sustain the investment, the HVAC investment? And then, even if we heard a lot of negative stories, we found good examples of functionality and or resource generation. So in these hospitals and RHUs, essentially, mas magaling silang mag-handle ng resources nila, ng income nila from PhilHealth, and they know how to manage the infrastructure, the HVAC investments. That's why they were giving out better utilization rates as compared to the others. And recommendations. So, funding, contracting, and contract management. We recommend that the facilities be organized, facilities to be supported by HVAC be organized into sets or lots or branches that can be offered to would-be contractors under contracting in lots approach, preferably on a turnkey basis. Most of the stories that we heard from the RHU is that we negotiate with one contractor and then hindi kasi nagde-deliver yung mga contractors. So they provide the infrastructure and then what? You don't get the equipment. Or either they provide the equipment or you don't have the infrastructure. So when we say contracting in lots, we suggest that you contract with an entity which will provide you with a complete facility. Say you give me a BHS, a working BHS, then you do your contract around that. Parang ito yung mga gusto namin in the BHS. Provide us with that one. And then, replace the current practice of incremental multi-year infrastructure funding with finish one at a time but quickly. So instead of upgrading the entire hospital, why not focus on several sections? Tapusin muna natin to and then let's move on to the next. Monitoring and commissioning. We recommend that you hold an initial project meeting with all stakeholders, including DOH, LGU, PhilHealth, health facility, on the rationale, specifications, schedule, equipping, and other deliverables. We heard stories where the MHO would just say na, bigla na lang dumating dito yung contractor, magtatayo daw sila ng sewage facility. So hindi nila alam kung paano na plano yung lahat ng yon. So we suggest that we involve everyone, all stakeholders, para maayos yung flow ng investment. And then we require signage indicating the amount and schedule of completion. We found these in some but not all investments. Formulate a manual of operations for the entire commissioning process. And address all issues on the punch list before final payment of the contractor. Yung iba kasi, siguro hindi, since doctors ang nagsasign ng punch list, they're not engineers, so they cannot really look at everything. So sometimes they sign and then hindi ko pala tapos. Pero sa side ng contractor, that's done, that's signed. So hindi mo na siya mababalikan. How to ensure sustainability. Explore how DBM requirement limiting the proportion of ERA that can be spent on personal enrollment can be waived. So ito yung pinaka-issue na narinig din namin. Hindi kami maka-hire ng tao kasi nasa cap na ng DBM. So kahit malaki yung facility mo, pero kung umabot ka na sa cap, cannot get more people. Seek national government support for an augmentation budget for human resources in lieu of current direct provision of them through various staff augmentation programs. They have different roles and responsibilities. If you're provided by the national government, one of the provinces that we visited, they said that they cannot do clinical work, so nandun lang sila sa reports, so they cannot handle patients. So, kung ganon, doon nagkakaproblema. So that's why there was a suggestion na why not provide augmentation budget for human resources instead. And then declare a blanket accreditation of all LGU health facilities that have been licensed by DOH for specific public health services. We have encountered RHUs again na matagal na birthing home, it's a functioning birthing home, may doctor, may entity. Kaso hindi siya accredited ng PhilHealth due to some document requirements. So, kung ganon, hindi siya makakuha ng income from PhilHealth. Again, the number of mothers going to that facility can be limited as well. Implement the fee retention or at least establish a trust fund for health in each LGU so that these revenues can be ring-fenced. So, what is for health